Hi everyone, my name is Alice Davies. I'm the education midwife and I'm going to take you through a short video about fluid balance. So the aims of the session are to improve our understanding of fluid balance charts, improve our completion of fluid balance charts, and understand the barriers to correct completion. So when do we start a fluid balance chart? Well, when we've got a woman particularly on IV fluids, if she has an indwelling catheter, if she's on any IV medications, there's known or suspected sepsis, or if we have acute kidney injury suspected or known. What is fluid balance? Well, fluid balance is a term that's used to describe the balance of input and output of fluids in the body to allow the metabolic processes to function properly. So it's really important that we maintain homeostasis. Our human body needs a fluid intake of about 2 to 3 litres, allowing us to keep the balance of nutrients, oxygen and water, which are necessary to provide a stable, healthy internal environment. Our output needs to be roughly equal, although insensible losses may give a slightly positive balance on charts, and that is okay. So why do we monitor fluid balance? Well, we know that injury or illness can affect our fluid balance. If you think of a woman suffering a massive obstetric hemorrhage or who presents with severe sepsis, hypoperfusion of vital organs can occur if she's got a lower circulating volume caused by dehydration. Monitoring fluid balance can be done in 3 ways, so either by clinical observation, blood biochemistry results, and/or fluid balance charts. Now, fluid balance charts are the most simple, cheapest, and most objective method we have. Our physical assessment of fluid status can be through vital signs. So is she hypotensive, hypertensive? What's her respiration rate? How is her temperature? Overload might present with tachycardia, hypertension, increased respiratory effort, noise, maybe a moist cough. Fluid depletion can present with hypotension, postural drop, a lowered pulse pressure, rapid shallow respirations, and a rapid, weak, thready pulse. We might look at her skin. So have we got skin elasticity, tissue turgor? Is the skin dry and less elastic because of dehydration? Is there a presence of edema, which could indicate overload? And what's her capillary refill time? Ideally, we want this to be below 2 seconds. Is her skin warm, and is her skin of a normal colour for her? We can also do a facial oral assessment. So are her mucous membranes dry or moist? So particularly her mouth, tongue, conjunctiva or saliva, maybe they're thick, sticky, and she's got copious amounts of saliva or frothy and overload. Or has she got sunken facial features, particularly around the eyes, maybe indicating severe depletion, or are there signs of edema? Thirst is a late sign of dehydration. So fluid intake is regulated by thirst. It's our natural response to fluid depletion. So the osmotic pressure of blood increases, water is drawn from the cells and into the blood. So the movement of fluid out of the intravascular space and into the interstitial space is dependent on that opposing osmotic and hydrostatic pressures. So hydrostatic pressure is determined by the pressure exerted at contraction of the heart and the resistance of the vessels and capillaries. This pressure forces fluid molecules small enough to pass through the membrane out of the vessel and into the interstitial fluid. The opposing osmotic pressure is determined by plasma proteins that are too large to pass through the membrane even under pressure. Osmoreceptors in the brain can be dehydrated and stimulate that release of the ADH hormone, and that sensation of thirst is then created. The adrenal glands produce aldosterone, which stimulate the reabsorption of sodium, and then the water from the kidneys means that less is excreted. So who is responsible? And it's important here to highlight the importance of monitoring and escalation. So if we think about our trained staff, we've got trained midwives, nurses and operating department practitioners, ODPs, who are going to be working across the multidisciplinary team, but particularly with our women. Their role is to identify patients who need fluid balance monitoring and communicate via the EPR, so that's our BadgerNet tool currently, and handovers. Clarify the up-to-date plan with the obstetric and anaesthetic teams and with our support workers. We need to communicate the plan for fluid balance with patients and visitors, maybe housekeeping and any colleague who may assist with, provide or remove fluids. We must ensure the accuracy using charts on our EPR and reviewing the cumulative measurements 6 hourly. Escalate promptly to the medical team in case of developing imbalance, deterioration or concern. If you think about our support workers and student midwives, it's really important they recognise the teamwork and communication across the MDT and ensuring those accurate measurements are fulfilled. Making sure the chart is complete and accurate, and we're using appropriate equipment, so maybe scales or urometers. And if you're not sure how to use them, then please do ask. And inform trained staff or the coordinator with any changes, deterioration or concerns. Our doctor's role is very much for that daily review and the overall global picture of health. So is there an indication for monitoring? Is it still necessary? What is the goal? Document specific instructions such as restrictions. So if preeclampsia, we're on restricted fluids, and what is the frequency required of monitoring? Reviewing the charts, what is the current balance and what does this mean for the overall picture for the woman? An escalation plan or the need for it. Who do the nurses and midwives need to escalate to, when, and also thinking, do you need critical care input? Patients themselves, if they're going to be involved in monitoring their own fluid balance, must be able to demonstrate capacity. So they've got to understand the information, retain and recall when asked, especially if they are to complete charts or perhaps complete a paper chart in order for you to be able to transcribe that onto the EPR. Trained midwives then need to calculate or at least review accurately those cumulative measurements. So you'll enter the amounts and ensure that they are correct and then review what the calculation provides. So it's important that we recognise kind of how much is being presented when we have a look at our jugs. So here you've got your 750ml jug, 150ml cup, a 200ml cup and a 300ml mug of tea. And it's important we also understand when we're reviewing fluid balance, what are the indications? So have we got increased fluid output? Is there diarrhea and vomiting with an added risk of dehydration or severe electrolyte disturbance? Have we got high urine output? Maybe there's polyuria. Has she got resolving AKI or concerns with diabetes? Is she on any diuretics? Has she got a urinary catheter in place? Perhaps she's had surgery. And is she continent, which is also important to manage? Have you got a post-operative patient who needs to be closely monitored, a large open wound, perhaps a drain is present? And has she got any increase in sensible losses, so sweating, maybe a sustained pyrexia or a high respiratory rate, which can actually lead to a fluid loss of over 500 mils in any 24-hour period? Then thinking about our reduced urine output, has she got oliguria? So a low urine output would be less than 0.5 mils per kilo per hour. And this can be an early sign of poor renal perfusion. So most common causes would be hypotension or hypovolemia. Anuria, so that's the absence of urine. Again, it's really important to flag this early. And the risk is we've had patients with acute kidney injury or chronic kidney disease. So if you have a raised creatinine blood level combined with a low urine output, this is likely to be AKI. And the kidneys are basically not effectively filtering the blood or reabsorbing the vital elements and then excreting others. So we need prompt identification because it can lead to very serious complications if left untreated. There are certain medications which can increase the risk of AKI, and patients on these need really careful fluid balance monitoring. So we're unlikely to see women on contrast mediums or under chemotherapy. However, these two would necessitate fluid balance monitoring. But we may well see women who are on antibiotic therapy, so particularly antibiotics that are high risk, gentamicin, acyclovir and vancomycin. So we really must monitor throughout the therapy and for 24 hours after the last dose. ACE inhibitors and diuretics also are often held in acute kidney injury. What can reduce oral intake? So there may be an impaired swallow, perhaps there was some complications after general anaesthetic, impaired thirst, she might be on IV fluids, therefore not feeling that thirsty, enteral feeding, nil by mouth, maybe she's pre-surgery, or on a restricted diet, for example, if it's preeclampsia, perhaps she's being restricted to 80 mils per hour. We also have to consider the women who have acute illness. So monitoring fluid balance will help to monitor acute illness and or provide an early recognition of further deterioration. And for some illnesses, the fluid can move out of the vascular system and into the extracellular space outside the bloodstream. So this fluid is still in the body, but it's no longer in a useful space. And so patients might develop a low urine output due to the hypotension and hypovolemia. And this is often caused by leaky blood vessels and can be secondary to ischemia, trauma, or inflammation. So conditions such as sepsis and malnutrition, acute pancreatitis, liver failure, or bowel obstruction. And hopefully, we shouldn't see much in the way of bowel obstruction or pancreatitis, potential for liver failure, but we need to be aware of them. So there are some barriers to completion, and how can we overcome these? So we need to understand the importance of fluid balance for women, utilise our support workers to complete our charts, and allocate and make sure that all fluid balance charts are reviewed at least 6 hourly. And you can use some sort of visible marker on the patient's bed, maybe a whiteboard, and also using badgenotes. And it's really, really important that we try and ensure that the reasons for poor documentation are addressed. So often it is inadequate training of the team. So making sure that we are disseminating the information. So at handovers, are we reviewing and asking, does this woman need a fluid balance chart? And if the staff do need any additional training, then flagging it to us as the education team for one-to-one support. Or if you are feeling like you're informed yourself, sharing that information more widely across the team. Most studies that report less than half of healthcare staff feel they've received enough adequate formal training on how to use the fluid balance charts. Now, this will be made easier with Badgernet now because it is going to calculate the cumulative amounts of input and output for you, but we still need to be making sure that we're accurately putting that information into Badgernet because the tool is only as good as the information it's given. And that accurate record keeping is really highlighted in the NMC update of 2018 for fluid balance. So incorrect recording of actual or potential fluid balance disturbances, really can lead to incorrect management for women. So we've got to really address this and support each other. So hopefully with that, we can, on the whole, understand that the women who present to us are often well. We've got to be vigilant and aware of the times, and maybe maintaining that accurate fluid balance can prevent more severe illness. Really communicate with the woman and her family. Is she aware of the plan? Communicate across the wider MDT. So do you know when to escalate? Have you got a plan for a review of the fluid balance? Talk about it at handovers and include your wider team. So think about your anaesthetists, anaesthetic nurses, and if necessary, the critical care team. And really think about that accuracy. Measure your volumes specifically. Don't forget to wear your pads and look at blood loss. So I hope that's helpful. Our next session, or part of the session, is going to move on to looking at how to document on Badgernet, and Sarah will take you through that shortly. Thank you.